988 implementation, which has a view really that takes into consideration really adults and adult focused care. You can go to the next slide. That'd be great. And I'll sort of walk through what the difference is and where customization begins for children and why it's so important. There are multiple states that really have truly customized their children's behavioral health crisis system. New Jersey is one, Connecticut is one, Oklahoma is one, that have really said we want to actually pay attention to the differences between adults and children and get to best practice, which I'll define in just a second. So the first thing that we want to make sure that we pay attention to in the customization for children really has to do with listening to parents and caregivers at the time that they first begin to identify that something is really going on and happening, and really not doubt that when they call. So when a parent calls and says, hey, something's going on, I don't know what's happening for my child, then we actually want to just go. We don't want to debate that. We don't want to ask additional questions. We want to make sure that when parents ask for help, we just go. If I were to say one of the most challenging parts of getting a customization for children, it would totally be in helping people understand how important that first phone call is in really supporting parents at a time when they are at a place in which they pick up a phone and call a public system and ask for help. That first moment is the moment in which great change can happen. So, but it's also the most difficult in terms of how do you build a system around that and how does that work? So in building customization, we really want to pay attention to how that system is designed to talk to parents right up front. How do we actually respond to young people who reach out for their own help, who say, I need assistance, I need some help, and how we pay attention to the system partners, the people who work with young people on a daily basis, schools, pediatricians, law enforcement, and the engagement of these other systems in terms of this work, how that's all coordinated and paid for is a really, really important part of the work. So you can go to the next slide. I don't know if you're going to go that. Great. This slide is perfect. So when we talk about customization for children, the ultimate model becomes mobile response and stabilization. That's what we consider it more at the national level. The 3 states that have implemented to full capacity, it's called mobile response and stabilization. Many states are working towards that. They've made great progress in things like 24/7 access, connect to families, listening to parents. Not all states have gotten all the way down the field, but many have gotten down the field in terms of just moving, their capacity along. So let me just put it into context. The first part of real customization for children is in that first phone call, someone to contact, having the ability for a parent and caregiver to reach out and ask for help and have that ask be understood and heard and connect that parent to help without doing things like linking them through additional suicide screening and additional tools that we might use at the single point of access for care like 988 is designed for the person who's in crisis to call. What we're asking for is the ability for who's ever answering the phone to understand that the parent is calling and asking for help, and they, as well as their child, are now in a state in which there's some level of escalation that is important for us to actually understand and consider. And it's not just the child who's experiencing a crisis, it's now a parent in the role of a parent who's experiencing that crisis. So that's someone to contact. It's so important. Training for that someone to contact is very important. Then the team. There's a team that goes. That team needs to be trained in how to work with children, how to actually engage parents, how to work within the context of a trauma responsive system that understands the connection to higher intensities of service, and what the scope and breadth of that child serving system is. How many organizations within the state are actually providing some type of resources and care are really important. That response needs to be in best practices within 60 minutes, anywhere within that service area. And it is, those teams are available to families up to 72 hours while they're really completing some form of an assessment that helps understand the broader context of what that crisis is, how that crisis is happening. Some families, that's enough. That 72-hour, 24-hour response within a 72-hour window is just enough for them. For some families, as we heard earlier today, it's not enough. And so we need really up to 8 weeks of stabilization services in children's space, customization for children. Stabilization always means in the home. We're always looking at, services and supports going into the home, schooling community for these young people, not taking the child out of the home. This is a really important consideration when we talk about children. The second that we take these children out of the home, we actually introduce additional experiences for the child that we now have to mitigate against. And so it's really important for us to pay attention to that understanding of what stabilization looks like, and really the development of what I will call a system to support, which you will hear in the Simpson model really is that stabilization component of a safe place to be. We would argue that there needs to be also the connection to the other parts of the system that can support these young people and families. For many young people, that customization means that we're really paying attention to how we're going to get that young person back into school, into their regular activities. For many of these young people, they're not ready for formal interventions. And that 8 weeks of stabilization is about supporting the family and preparing young people for those formal interventions, which are incredibly important. Next slide, please. So a couple just things real quick. The whole goal of any crisis system for children is to keep young people in their own homes, schools, and communities. The more we can do that, the better off young people are. And we're going to support them and their families with trauma responsive care. We're going to promote safe behavior within the homeschooling community. So we need young people to be safe, to feel safe, to have the tools that they need in order for them to be successful. We're going to reduce the use of emergency departments, hospital boarding, and detention centers. And we know from the states that have been successful that the more availability we have, the quicker teams move, the less likely it is that these young people end up in emergency departments and inpatient care. And we're going to assist youth and families in accessing and linking to the services and supports that they need. Sometimes the work is really just about making sure that there's a good connection to the next thing, and the idea that we're going to actually support young people in preparing for formal intervention. Next slide. Customization is really starts here. When we talk about customizing care for children, one of the things that's really important is the crisis is defined by the parent, the caregiver, or the young person themselves, and not by the person who calls. The person who calls, we have to get whether it's the school, whether it's a community member, we have to help them get the parent onto the phone so that we're not operating outside of what parents understand as care. We need to actually engage parents at this particular time. It's a really important grounding concept in systems of care that parents and caregivers are included in all of in any part of engagement. And we don't get better connection for parents later, right? So we really need to understand that making sure that first contact is very friendly for families, that it's very supportive, and that we know how to describe how it is that we can be helpful. That we meet the parent and caregiver's sense of urgency is also an important concept because many of the calls are going to be driven by parents in the first place. They're the first ones to pick up the phone, they call, they ask for help, and if they don't get help, they hang up the phone and they'll say, the system is not supportive for me and it's not supportive of my child. Either I don't understand the definition of crisis or the people answering the phone don't. And they'll wait until it's much further along. One other thing I just want to say is that the ability of 24/7 access to care is really complicated for states to do, but also a defining factor in real systems transformation. When states get to that place where parents call at 2 a.m. and ask for help, it means that parents can become reliant on that system and know the system will be responsive. Next slide. And just outcomes are really important. And so I'm just going to pick a few of these. You're more than welcome to take a look at them later, but we're going to pay attention to a lot of different things when we're looking at how that system has been helpful or not helpful. Is emergency room visits, just as an example, where touches within inpatient care, school attendance, graduation, suspensions, expulsions. We're going to look at things like the connection in child welfare. How many moves do they make in foster care, and what does that look like? Police responses, and whether or not law enforcement has to be more active. I just want to also say that I failed to say that in customization for children, we never co-respond with law enforcement. Law enforcement are partners, tremendous partners in work, and are included in all of the preparation, all of the planning, all the understanding of how mobile response and stabilization works, but do not co-respond when it comes to an actual crisis situation within the home. I think that's all of my slides. So,
yeah. So, Liz, I just want to flag or highlight a couple of things that you said that struck me when we first spoke a few years ago and strike me again. One is having to do with the idea of proactive versus reactive, like providing mobile response that isn't just because it's a crisis as if everyone in the system has defined it as a crisis, but because parents are seeing something and they need to know how to respond, or they're worried about it, they don't know if it's a crisis, which is really a different and really important approach, I think, to get upstream of problems and head off some of the more acute things. The other thing I want to flag, and something Kristine knows I've said in many conversations about what we're calling our unified crisis continuum in Illinois, is this idea of customization, that kids are not adults and they don't operate with the same, like even at the most basic level of their ecology, like kids operate within a family, within a school, within a community, whereas adults have have potential for a much more direct line to help. And so you have to build things. The structure has to reflect that kids access services differently. So I just want to flag both of those things for everyone.
And then parents and children are interconnected. Yes. If you're a parent watching your child struggle, it's not likely that you're not going to struggle yourself and try to figure out, how do I help?
Right, which leads me to the third thing, which is the family-driven, like really thinking about, like, what does this mean for the family and elevating that perspective. So before we turn to Kristine and ask her to describe the Illinois version of what's going on, is there anything particularly innovative that you've seen anywhere in the country that you want to flag for us? It's like, here's a promising practice that we're looking at that is, that could be something we want to build more of.
Yeah, sure. I'll give you 3 quick examples. In Connecticut, they've really built a lot of interconnection between mobile response and stabilization and their school systems and how those schools respond. There's a lot of, engagement. They have a whole process in which every school has a memorandum of understanding with their local mobile response teams. There's a lot of engagement and interconnection that you can see how much effort that Connecticut has put into that. In Oklahoma, where there's a lot of challenges around the rural and more frontier type communities, the engagement of law enforcement, not as law enforcement going to respond to a situation, but the law enforcement who can get there faster, providing technology to connect, using iPads to connect families to immediate care while they're trying to get teams there has been really helpful. It is not it's moving towards the best practice. The best practice really still is to get a child-specific team into the home of that family as quickly as possible. But it's really challenging to do that in more rural communities and certainly in frontier spaces. And then the third practice that I'll talk about is New Jersey, who said we're going to recognize trauma as a really important component in the children's behavioral health system. And so we recognize that every child who's removed from their home because of concerns of abuse and neglect require immediate attention, and mobile response and stabilization meets them at the door. And that's really important. It's an important conversation that happens. It's not a complicated conversation. It's more of that assessment that we talked about happens the mobile response team gets to say to this young person in the language that the child will understand. So they use multiple tools in order to communicate. But basically says something big just happened. And because something big just happened, you might have a hard time eating, sleeping, paying attention. School might feel real different. It happens for some children. It doesn't happen for all. But if it happens to you, we're here. We know what to do, and we're here to help you. And they turn around to the foster parents and have that same exact conversation. We know what to do to help this child. So they're really teaching foster parents right up front that trauma is important. What happened to this child is really important, and that there is help available immediately for them. And this is how you use it. This is what it looks like. In that innovation, New Jersey was able to see a significant decrease in the overall reliance of emergency departments, inpatient care, and residential care, and that the majority of young people who got that intervention right up front in the pilot stayed in their first bed. It was 47 out of 40%. Stayed in their.
Yeah, just more along those lines of proactive versus reactive, like recognizing that all of these kids are at risk for trauma-related problems and kind of heading it off by educating everyone and trying to get a response in early.
That's right.
Okay, well, thank you, Liz. I'm going to pivot to asking Kristine to tell us about Illinois. The programs that are underway in Illinois for delivering mobile crisis response to youth. Kristine and I work closely, so I'm looking forward to hearing the plans and any upcoming innovations. So go for it, Kristine. Let's go to the next slide, I think.
All right. Dana, thank you. As always, it is just a pleasure to work with you. As Dana said, I'm Kristine Herman. I'm the Bureau Chief of Behavioral Health for Healthcare and Family Services. I just got to say, I'm so ridiculously honored to be on this panel with Dr. Weiner and Liz Manley, who's one of my personal heroes. These two women are just absolute powerhouses in children's behavioral health. We can all learn so much from what they bring to the table and their rich experience and their current efforts. So I just want to say a heartfelt thank you to both of you for being here. And honestly, we've been so impressed with what Liz and her team have done over the years in Jersey in their implementation of the mobile response and stabilization services that we've really tried hard to model that work in Illinois, and at least around their principles that they have implemented. I just want to acknowledge that we have a lot of work left to do to realize that kind of fully robust, child-centered system. But I'm also really happy to say that we have been putting building blocks in place. So I'm going to take a few minutes to talk about some of those components, and then we can have some additional discussion maybe about how we put them together better and some of the gaps that we might see in that system. Okay, so next slide. Before we get too much further into the discussion, I do want to share with you our branded healthcare and family services vision, and it is all about improving lives. We're striving to implement this by valuing our staff, by always looking to improve and working every single day to earn your confidence. It's a tall order, but this is generally our North Star and why we come to work every single day. And so I'm trying to more highlight this vision for HFS because I think that everybody needs to understand where we're trying to get to. Next slide, please. Okay, so we've talked about where we want to go. I want to go back and talk a little bit about where we are. And I want to focus first on kind of the first two pillars of our current mobile crisis response system. So that first pillar is someone to call. So here in Illinois, we have a mix of hotlines that are available. The most recognizable one for our youth in crisis is the Crisis Assessment and Referral Entry Service, or the CARES hotline. This is a 24/7 hotline. It takes calls for both youth and adults who are Medicaid eligible or who are funded under our Department of Human Services and who may be experiencing a mental health crisis that could require their admission to a psychiatric hospital. So note that definition. We do have a Children's Mental Health Act that requires all publicly funded youth to receive this pre-admission screening, and it is meant to determine if they can be safely stabilized in the community or if they need more intensive services. So calling the CARES line is kind of the first step that has to be taken to ensure that that screening occurs. So that's just a very quick overview of the CARES line. We also have a statewide network of 988 call centers that Liz had mentioned earlier. And that's where we have our trained call takers to answer calls, talk to individuals who need support. It is very adult oriented at this point. But the majority of these calls, I mean, they're saying around 85% right now are actually resolved by the call taker just supporting the individual during the call, and they do not require any additional response or intervention. And we also have this patchwork of individual crisis lines that are staffed by local community mental health centers and then other community agencies. So that's a very high level overview of our someone to call pillar. So our second pillar is somebody to respond. So Illinois Medicaid has a statewide network of designated mobile crisis response agencies that are mostly community mental health centers. Now we have some certified community behavioral health clinics that are coming into that realm. And these designated mobile crisis response agencies are mainly dispatched through the CARES line that I was discussing earlier. And they mostly serve the Medicaid eligible adults and children, more of a focus on children at this point. Many of these agencies also have separate state grant funding to serve individuals who are not Medicaid eligible. And then there are a few of the 988 lines that do have some mobile crisis response dispatch through agreements with their local mental health centers. So again, just a quick overview of our someone to respond pillar. We can go ahead and go on to the next slide. Okay, so once that mobile crisis response is dispatched, there's some fairly standard services that are provided as part of the mobile crisis response event, and then following the crisis to try to ensure that that person is stabilized. So mobile crisis response staff are expected to go to the location of the crisis and respond in person. Unless there's been a specific request from the individual in crisis for a telehealth response, or if there's a safety concern that needs to be addressed by the mobile crisis response staff, they can meet at a mutually agreed upon location that is safer for the individual and for the staff. The mobile crisis response staff are to provide immediate crisis de-escalation. They're to complete a crisis screening and assessment. They can do brief therapy if that's needed to de-escalate. They're supposed to do crisis safety planning with the individual and with their family, and then to utilize all of that information that they've gathered during that crisis event to establish a crisis disposition that the individual can be safely community stabilized, or if that individual needs to receive more intensive services. So we can go on to the next slide. Okay, so there's several post-crisis services that are available if the crisis disposition determines that the individual can be community stabilized. So the crisis safety plan can authorize crisis stabilization. That includes having a crisis staff stay with the individual in crisis for as long as it takes for the person to return to a better functioning level. That individual can also be referred to a mental health center that can complete or update their integrated assessment and treatment plan to include additional outpatient services to assist that person in staying out of crisis. And then for youth who are under the age of 21 and who are Medicaid eligible, they can also be referred to the Pathways to Success program if they meet that eligibility criteria, or the Family Support program for ongoing community-based services. Now, if the crisis disposition determines that the individual cannot be safely stabilized in the community, then the mobile crisis response staff are responsible for connecting that individual to more intensive services, either in an emergency department or through admission to a psychiatric hospital. So let's go ahead and go on to the next slide. So I mentioned a couple of specific children's services, and here's where we have a few more of the components of that full, mobile response and stabilization service that Liz was describing. So Pathways to Success is for Medicaid eligible youth, as I mentioned, who meet criteria as class members under our NB consent decree. It includes 2 tiers of evidence-based care coordination, plus intensive home-based therapeutic mentoring, family peer support, and respite. A lot of those were included on that slide where you kind of saw the full continuum of services that need to be available for youth in crisis. So we do currently have statewide coverage for care coordination under Pathways, because our designated mobile crisis response agencies are also our Pathways care coordination providers. We need to continue building capacity within those providers to accept all the Pathways referrals. So we're still working on the provider network for those other services that I mentioned. So the intensive home-based therapeutic mentoring, family peer support. In addition to that, we do have the family support program that is available to every youth in Illinois who meets the eligibility criteria regardless of their Medicaid eligibility. It is a state-funded program. It does include all of our Medicaid-covered community-based outpatient services. It also covers additional supportive services. And then for youth that meet eligibility criteria, it covers residential treatment for those youth. All right, so let's go to slide 7. Okay, great. Thank you so much. So acknowledge that we have some of the components that we need, but we do truly need to pull them together into a fully functioning mobile response and stabilization service to really build out that third pillar of crisis services, which is having a safe place to go. And to accomplish this, actually Dana had mentioned this, we have begun the process of developing Illinois' Unified Crisis Continuum. That does include collaboration between the HFS, and then we bring in the divisions of mental health and our substance use prevention and recovery that are over at the Department of Human Services. Now, through this process of developing this Unified Crisis Continuum, we are working to braid funding from Medicaid, from state grants, and then from commercial insurance to develop that cohesive statewide crisis system that ensures that everyone in Illinois can access mobile crisis response anytime and anywhere. We're also working together to implement that single statewide mobile crisis response dispatch that will ensure that if somebody needs a response, they get it quickly. We know that we need to expand the available services in our crisis continuum, and that includes urgent care, crisis stabilization units as part of that safe place to go. So we're bringing those on through our certified community behavioral health clinic demonstration, and some of those are going to be operational in the next year. So that particular component is not too far away. But most importantly for our youth, we really need to enhance the family orientation of that initial call and that initial response. We need to expand the mobile crisis response service to include those more robust follow-up services that link youth directly to supportive services like the ones that we have in Pathways in the Family Support Program, to ensure that they have those additional supports in their homes, in their communities, and then in their schools to help them continue to thrive. We're also working to support the development of family-run organizations to connect directly with our Pathways providers and our mobile crisis response providers to ensure that that family voice is really at the center of our work and bringing them more into the center of this unified crisis continuum. So again, I just want to acknowledge we've got a lot of work to do, but we do have the commitment from our current administration and from our sister agencies to put the effort into getting this done. It's not going to happen overnight. I mean, Liz, maybe you can tell us like how long New Jersey worked at this until you got it sort of right. But we do have a dedicated team that is really trying to keep this vision in the forefront as we're trying to really improve this mobile crisis response and the overall children's behavioral health system in Illinois. So those are the end of my prepared remarks.
Okay.
I'm happy to take any questions.
So I do want Liz to answer the question you just posed, but I'm just going to give offer one reflection because, of course, I'm familiar with this story and what Kristine is working on. And Kristine, you kind of answered my first question to you, which is what's on the horizon. So, but seeing all of this, I'm always struck in Illinois, and maybe this is true in other places, Liz can tell us, but there are so many different things. And sometimes we think like, oh, well, the more we develop, the more programs, like there will be more options for people. But what we hear from families is, I don't understand the difference between all these things. Which one am I supposed to go to? Can you just put it all in one place? So that tension of like wanting to have specialized things that have different functions, but not wanting to confuse people with the options. Like I'm just not sure we've cracked that nut of how to overcome that. So Liz, I don't know if you have reflections on that or Kristine's other question about how long did it take New Jersey to get it right?
Well, listen, I would argue that New Jersey's still trying to get it right? So it's like it's an evolving process of where you go to. They've been at it for 25 years now. So they have hit many of their targets, right? 24-hour access, 60-minute response time, all of those things that we're talking about today. And they've had the impact that you would want, the closing of, the state hospital and bringing back young people from that state residential. But it's an evolving process. So I just say, like, it's always going to be something. In terms of the, I think the second question, which was, now I lost it.
Oh, I was just talking about the complexity versus
yes.
simplicity. Like, do you put it all in one place or do you do a kind of hyper customized set of programs? It's hard to know.
Make it simple. Simpler the better for folks to understand what it does. And then the in what you call it, simple, right? Mobile response and stabilization, in-home services. And then in the in-home network, we actually specialize within the in-home network, right? Around who can provide MST or, multi-systemic therapy or functional family therapy or, who can work with children, who can do play therapy, all within the network. And then have the folks who are coordinating the care be the ones who have to help families understand that rather than families having to understand it themselves, right? Anytime you can build in navigation for families, peer support and families helping to figure out, hey, by the way, in-home services would be helpful. Then we're going to have a care coordinator who's really going to help you pick out the best person to actually help you. That's the most impactful, I think. One of the cool things in New Jersey is it's a very simplified service array. It's not complicated. It fits in two categories: transformational tools, that's mobile response, it's intensive care coordination, it's youth and parent peer support, and it's the single point of access. Next slide is the service array, and it's outpatient, inpatient, in-home, right? Like it's really not complex when you think about how families think about what they need.
Yeah, and one of the things the technological tools are allowing us to absorb some of the complexity behind the scenes.
That's
so we
right.
can show families something that's simpler, but then we can do the necessary braiding of funding and more complex things that Kristine was talking about. Okay, so I have a number of questions for you both to answer, but I just want to mention that if anyone who's listening to us, it looks like 38 people in here. If anyone who's listening to us has questions, if you could put them in the chat. I don't see the Q&A function in the breakout room, so if you put them in the chat, I can read them and moderate and pose them to our panel. But the first question I have is, and we've kind of touched on this in various ways, but what are the biggest barriers that you confront to implementing these services? And any thoughts on strategies to overcome those? But what's the hardest part of all this? You might have different perspectives on this, but either one of you.
I'll give you the national perspective, and that is that children don't rank high enough in the in the conversation sometimes for there to be understanding about what the impact of new systems developments. We're always competing and having to demonstrate that customization is necessary, like that children aren't small adults, and that parents are important in the conversation. They can't leave them out of the conversation up front. So that's one of the big challenges. So the competition for time and attention, like 988 rollout was just an example of, how do children's behavioral health directors get at the table to be part of those conversations, which is really necessary. And then the other tension table is how do you actually get the system design to sort of infuse in the community so that people understand the power of things like mobile response and stabilization, and understand that it is a game changer in terms of how funding works. So there's a wrong pocket issue, right? Because most states spend a lot more money per child than states that have a good and modern system, right? So if you have a good and modern system, you're going to have efficiencies in how services are delivered. That means that you're going to probably spend less per child in accessing care. And putting mobile response and stabilization requires investments, big investments in front, getting teams ready and making sure they're actual in the right place at the right time. But the payback in that isn't necessarily going to be seen in the behavioral health system. It's going to be seen in the education system where children graduate on time, in the juvenile justice system where you have less young people in detention centers, in residential care. And it's hard to actually have those sort of complex conversations around how this service delivery is so important.
Mm-hmm. Yeah, so I hear that as like both the need for customization, the need for dissemination. Your comment just now hit home for me. One of the things, it's my personal pet peeve, but when we try to highlight the importance of having things customized for children, when I hear, well, that's like a specialty population, I'm like, no, it is the whole population. Like everybody starts as kids. Like it's not like this little offshoot that like we'll think about that later. That makes me nuts. Anyway, Kristine.
Well, I was just going to say, a data point though is that the majority of adults with mental health challenges, serious and persistent mental illness, starts in children.
Right.
And if you can actually do things in the children's space, you can make a difference in the adult space. And one quick data point: New Jersey's been at this for 20, 25 years. They have the lowest percentages of adults with serious persistent mental illness in the country. So, like it's not an insignificant conversation around those investments for children.
Yeah, and I am catching the comments in the chat. I'll highlight them in 1 second. Kristine, did you have anything you want to add though to this conversation about the barriers?
I mean, and ditto to everything that Liz just laid out. In addition, we've had mobile crisis response focused on youth in this state for 20 some odd years because of that Children's Mental Health Act. One of the things that we have seen is that there has been this culture that has developed around what that service is, how that service is provided. And now we're bringing in like these additional pieces, and we're trying to change an established culture. And that is extremely difficult when you have already existing systems. And frankly, HFS looks at things through the lens, just like we were saying, of adults. And then there's these kids that, we're going to try to figure out what to do with. So, one of the things that I'm trying to focus on now is that changing culture approach. How do we best do that? How do we support the providers that are doing this? How do we bring families to the table and make sure that we are all starting to see from the same viewpoint about where the system needs to go? And then how do I build in, the policies, the procedures, the funding that then supports that culture change? So that's really, I think, one of the biggest challenges that we're dealing with right now.
Mm-hmm. Okay, so we have thanks, Kristine. We have two comments in the chat. One from Dr. Lori Jones asking about what we can do to prevent kids, and I think we heard some of this in Liz's comments about this proactive response, but preventing crises and avoiding further get people from getting deeper into the system once an initial crisis has occurred. So and then we can take the next question also about culturally and linguistically competent services. Thoughts on either of those, though?
Yeah, let me just say that the first thing that I think is essential is that mobile response and stabilization is one part of a larger, broader continuum, right? So, infusing support in schools is important. Making sure pediatricians know how to, identify and actually access particular services and supports in a proactive stance. Making sure there's early intervention. All of those things are incredibly important. But even with a full, broad continuum of early intervention supports and services, infant mental health, all of those kind of things in place, at least my experience in New Jersey is that there's still young people who are moving in the direction of, a behavioral health crisis that require time and attention, and that really getting to them in the early part of the crisis, escalation by basically saying to parents, we're available and we can help you when you don't know what to do is just a really important part. And then you can prevent movement to emergency departments, inpatient care. You can prepare young people for outpatient services. You can prepare them for community supports and never have them touch on outpatient. So all of those kind of factors are really important because the real goal is to prevent from moving to the escalation of the most expensive, not just in cost to, the cost of the care, but the cost to young people and their families around residential care and inpatient care and what that means. So we're really trying to minimize the use of those interventions and really put it in a place in which families can ask for help easily, get that help easily, and making sure that we have an understanding of what's necessary to take care of.
Mm-hmm. Kristine, I want to draw your attention to this second question because I know you mentioned the work that you're doing to build out provider networks, and I'm just wondering what is on your radar as it relates to cultural and linguistic competence of providers, our ability to have providers, particularly in the mobile crisis space, that speak other languages and can work with non-native English speakers.
Yeah, it's a hugely important issue. One of the things that we are trying to do through our development of our behavioral health clinics, which are kind of our smaller, more community-based mental health centers that are supposed to be a little bit more nimble and community-oriented than our existing community mental health centers, to get them into the communities where we know that we have a lack of those kind of practitioners and providers who are a part of the community, who speak the language, and bring them up into this system. We have had some success with our Spanish-speaking folks that have come to the table to say, hey, we want to be a behavioral health clinic. We do our best to offer translation services so that we are able to communicate with them better. We're working to get more of our training materials into other languages. But I think that this is a particular area where we are going to have to continue to focus because we know we've just kind of started to scratch the surface there. Our managed care plans have translation services. They certainly can serve individuals from multiple cultures and multiple languages, but to really get it into the communities that understand those different cultures better is really where our focus is going to be. But hopefully that helps.
Yeah, thank you. And Sarah, I responded directly to your comment about streamlining access to residential treatment, which is partly the purpose of the Beacon tool, and I put the address for it in the chat. Happy to talk more about that if you're interested. I think I'm going to end with, should we talk about the federal climate or should we talk about the community focus? Let's just quickly, because it's kind of the elephant in the room, like in the context of the current federal climate, are there any ideas for proactive planning or thoughts that you have about, and I'm not asking you to predict what might happen, because none of us know and it changes every day, but more thoughts about like safeguards or things we can do to kind of stabilize and buffer people from experiencing the effect of that more volatile federal climate.
I'll just argue right up front that I think one of the most important things we can do is band together and talk to each other and be engaged in the work together, because I think everyone understanding how important these services are, how important addressing young people's needs are, the better we're able to articulate that, the more information we can share with folks who are making some of these decisions, the better off we are. And I think, the advocacy efforts for families coming together on those advocacy efforts are really important. So data is important, making sure people can tell the story is important. Those are, I think, the things we can do and have a lot of control.
Yeah, I appreciate those thoughts, and that is a positive note. Kristine, what did you put in the chat?
Okay, so